Have you ever walked into a patient's room and noticed their heart rate is just suddenly spiking, like they're sweating profusely through their gown, and they seem unusually anxious?
Yeah, that is a terrifying moment, especially for a newer nurse on the floor.
Right. Your mind immediately jumps to the worst case clinical scenarios.
Yeah.
You wonder if it's an infection brewing or maybe uncontrolled pain.
Or a severe medication reaction. I
Yeah.
mean, sepsis and pulmonary embolisms just start flashing your brain.
Exactly. You feel like you need to call a rapid response right that second. But clinical experience shows us it's often something entirely different. It's withdrawal.
Yep, it really is.
So, welcome to the Super Nurse Podcast, which is created by Brooke Wallace. She is a 20-year ICU nurse, an organ transplant coordinator, a clinical instructor, and a published author.
And just to be absolute clear, right up front, we are not Brooke Wallace.
Oh, right, we are not. But this entire show is built from her bedside knowledge, her clinical notes, and her signature teaching style. We are here to help you, the listener, apply what you learn in nursing school to the real, breathing patient right in front of you.
We're basically translating the textbook into actual bedside practice so you can walk onto your unit with total confidence.
Before we jump in, make sure to subscribe and watch the incredible new comic book-based video on YouTube. The link is right down in the description on our channel called Super Nurse Comics. You do not want to miss it.
Definitely check that out.
So today, our mission is breaking down substance abuse and addiction. We're going to translate the complex pathophysiology into plain English, show you exactly what clinical clues to look for, and map out the nursing priorities, anticipated orders, and medications.
And becoming a confident, critical thinker at the bedside really starts with getting our vocabulary straight, Because in healthcare, words matter.
They really do.
There are a few terms in this space that get tossed around interchangeably, but clinically, they mean very different things.
So let's define the baseline. When we talk about intoxication, we are talking about the acute state of being under the influence of a substance. It's the immediate, temporary effect the drug is having on the body.
And the physiological flip side of that is withdrawal. Withdrawal is the physical and psychological crash that happens when the substance is removed.
Right.
A great rule of thumb to remember for your clinical practice is that withdrawal symptoms are usually the exact opposite of intoxication symptoms.
So if a drug sedates a patient, taking it away wires them.
Exactly. If the drug makes them feel warm and fuzzy, withdrawal makes them agitated and miserable.
That brings up dependence, which I think trips a lot of people up. Physical dependence is a purely physiological state. Your body has adapted to the constant presence of a drug, and now it literally requires that substance just to function normally.
Without it, you go into withdrawal.
Right. Think of it like getting so used to your morning coffee that you develop a splitting headache by noon if you don't drink it. Your body is physically dependent.
What's fascinating is that anyone can become dependent on a medication if they take it long enough. I mean, a patient taking prescribed opioids for a legitimate back injury for 6 months will absolutely become physically dependent.
That's just a normal biological response.
It is.
Yeah.
But it does not necessarily mean they have an addiction.
Which is our fourth term, addiction, or substance use disorder. So if dependence is getting the caffeine headache, addiction is if you started stealing your roommate's wallet just to go buy that coffee.
Right.
It could ruin your life and get you kicked out of school, but you do it anyway. It's compulsive use despite severe negative consequences.
And the neurobiology really explains why this happens. Substances like alcohol, opioids, and stimulants flood the brain's reward system with unnatural, overwhelming surges of dopamine.
Just a massive amount of it.
Yeah, and over time, the brain, trying to protect itself from this toxic flood, it literally shuts down its own dopamine receptors. It rewires the neural circuitry just to survive the chemical assault.
So it's kind of like walking into a room where the music is blasting so loud it hurts your ear, so you put in heavy-duty earplugs.
Yes.
But then when the music turns off and someone tries to talk to you in a normal voice, you can't hear them at all because you still have the earplugs in.
That is a perfect analogy. The brain's baseline changes. The person isn't using the substance to get high anymore. They have to use it just to feel a baseline level of normal.
Wow, that really reframes it.
It does. And because the circuitry related to memory, motivation, and impulse control is altered, they experience intense, uncontrollable cravings. The evidence tells us this is a chronic, relapsing disease.
So if the brain rewires itself to counteract the presence of a drug, it makes total sense that pulling the drug away causes a violent physical reaction.
Oh, absolutely.
And that explains the most common and potentially dangerous substance emergency you will see on the floor, which is alcohol withdrawal.
Every single nurse, regardless of what unit they work on, needs to be prepared for this scenario.
Let's look at the mechanism. Alcohol is a central nervous system depressant. It acts like a heavy brake pedal on the brain.
Right.
When a patient drinks heavily for a long time, the brain realizes it's constantly being suppressed. So to keep the heart beating and the lungs breathing, the brain hits the neurological gas pedal to overcome the alcohol.
It forces a state of hyperarousal to counteract the depressant.
Now think about a patient admitted to your floor for a fractured femur. They aren't drinking in the hospital, the depressant is abruptly gone, but their brain is still slamming on that gas pedal.
And the result is a massive system overdrive.
So what does that actually look like when you walk into their room at 2 a.m.?
Well, that overdrive follows a highly predictable timeline. The mild or early signs typically start 6 to 24 hours after their last drink. This is when that gas pedal starts revving.
Okay.
You'll see their heart rate climb, you'll see hypertension, anxiety, profuse sweating, and nausea. You might notice fine tremors in their hands when they reach for a cup of water.
But wait, those symptoms are so broad? I mean, a patient with a broken femur might have a fast heart rate and be sweating because they're in severe pain.
Right, or maybe they're spiking a fever from an infection.
Exactly. This is where it gets tricky for a new nurse.
This is exactly where your clinical judgment comes in. You have to look at the whole picture and the patient's history. Because if we miss those early signs, we enter the severe window, which hits 48 to 72 hours after the last drink.
And that's the danger zone.
It is incredibly dangerous. We're talking visual and auditory hallucinations, grand mal seizures, and delirium tremens.
Delirium tremens, or DTs.
Yes, DTs are a massive, life-threatening autonomic nervous system overload. The patient is profoundly confused. Their blood pressure and heart rate are dangerously unstable.
And the mortality rate can be significant if it's not treated aggressively.
Very significant.
So we obviously don't want to wait for a seizure to realize how bad it is. How are we actively measuring this gas pedal effect at the bedside so we aren't just guessing?
Clinical practice gives us a very specific tool called the CIWA scale, the Clinical Institute Withdrawal Assessment.
Okay, the CIWA scale.
Yeah, it's a standardized checklist measuring things like nausea, tremors, sweating, anxiety, and sensory disturbances.
Yeah.
You assign a score to each, and the total score dictates your interventions.
So the CIW scale isn't just a random list of complaints. It's a direct measurement of how hard the autonomic nervous system is firing.
Exactly. The higher the score, the closer the brain is to short-circuiting into a seizure.
Wow. And based on that score, your bedside priorities kick in. Number one is the environment, right? You must decrease stimuli.
Yes. The patient's nervous system is already screaming. They do not need bright lights and a blaring TV. You need a dark, quiet room and severely limited visitors. Next is strict seizure and fall precautions.
That fall risk is huge. I mean, you have a patient with severe nausea, diarrhea, and extreme confusion. They're going to try to climb out of bed to use the bathroom, trip over their IV line, and hit their head.
It happens all too often. You also need continuous monitoring of their vital signs to catch those extreme spikes early.
When we do catch it, what are the anticipated orders? I know benzodiazepines like diazepam or lorazepam are the frontline medications.
Yep, the benzos.
But wait, if they're withdrawing from a highly addictive substance, why are we giving them another highly addictive medication?
It sounds counterintuitive, but in an acute crisis, it's a lifesaver. Benzodiazepines act on the exact same receptors in the brain, the GABA receptors, that alcohol does.
Oh, I see.
You are essentially providing a controlled artificial substitute for the alcohol. You are putting a safe brake back on the nervous system to sedate it and prevent the brain from seizing.
That makes perfect sense. Alongside the benzos, you almost always see orders for IV fluids and thiamine, which is vitamin B1. Why thiamine specifically?
What we know from practice is that chronic alcohol use destroys a person's nutritional status, specifically the gut's ability to absorb vitamin B1.
Okay.
And the brain absolutely requires thiamine to metabolize glucose for energy.
So without thiamine, the brain literally starves.
It starves, and lactic acid builds up, causing brain cells to die. This leads to Wernicke's encephalopathy.
Right, Wernicke's.
This is a severe neurological condition where the patient becomes profoundly confused and develops ataxia, where they completely lose control of their body movements and just stumble around.
They also develop eye abnormalities, too.
Yes. And if you don't catch it and give that thiamine, it progresses to Korsakoff syndrome, which is an irreversible, permanent memory disorder.
That's terrifying.
It is. Giving thiamine is literally protecting their brain tissue from dying.
Okay, so alcohol is a depressant that causes a hyperactive withdrawal. We must see that same boomerang effect with other depressants, right? Like opioids.
We absolutely do. Let's look at opioids, which includes heroin, fentanyl, oxycodone, and morphine. For opioid intoxication, the pattern is everything goes down.
Down, got it.
You'll see profound respiratory depression, extreme sedation, bradycardia, and pinpoint pupils, which is a huge clinical clue.
The nursing priority there is always airway and respiratory status. The evidence tells us the antidote for an opioid overdose is naloxone, commonly known as Narcan,
Right, Narcan.
which kicks the opioid off the brain's receptors and reverses the respiratory depression. But then, once that opioid is gone, we get the withdrawal. If intoxication was everything going down, withdrawal is everything going up.
Patients often describe the clinical picture of opioid withdrawal as the worst flu of your life, combined with a massive panic attack.
That sounds awful.
It's brutal. You will see severe agitation, profuse sweating, diarrhea, severely dilated pupils, hypertension, and insomnia.
I often see maintenance meds for opioid use disorder, like buprenorphine and methadone. I've heard people argue that giving these is just trading one addiction for another. How does that actually work physiologically?
Well, these are opioid replacements, but they have a much longer half-life and a different mechanism of action. They bind to the same receptors, which stabilizes the patient and prevents the horrific withdrawal symptoms, but they don't produce that extreme euphoric spike and crash of illicit opioids.
So it's kind of like giving someone trying to quit smoking a nicotine patch.
Yes.
It feeds the receptor just enough to stop the physical withdrawal panic, but they aren't getting that massive hit of a cigarette.
That is a highly accurate way to look at it. They also use naltrexone, which completely blocks the opioid receptors so the patient can't get high even if they try.
Okay, so we've talked about depressants where the crash is a spike. What happens when the drug itself is the spike? Let's talk about stimulants like cocaine and methamphetamines.
For stimulant intoxication, the pattern is massive systemic overdrive. These drugs cause a massive dump of adrenaline, noradrenaline, and dopamine.
Just a total surge.
Yeah. You see severe tachycardia, massive hypertension, euphoria, and dilated pupils. The massive surge of neurotransmitters causes severe vasoconstriction, meaning the blood vessels clamp down tight.
So the heart is pumping furiously against clamped down blood vessels.
Precisely. It places an immense strain on the cardiovascular system. The severe deadside risk with stimulant intoxication isn't respiratory failure, it's myocardial infarction.
A heart attack.
Right, a heart attack, cardiac arrest, and lethal arrhythmias.
So if the intoxication is a massive surge of energy and dopamine, the withdrawal from that isn't going to be seizures or tachycardia. It's going to be a total blackout crash.
We literally call it the crash. The
Okay.
brain has completely depleted its stores of dopamine and energy. There are no neurotransmitters left to feel pleasure, motivation, or even basic wakefulness.
Wow.
The patient experiences extreme fatigue, severe lethargy, a massively increased appetite, and profound depression.
What's the bedside priority there then? If they aren't going to seize, do we just let them sleep it off?
This is a crucial pivot for your nursing care. For stimulant withdrawal, the highest priority shifts from physical stabilization to mental health monitoring.
Okay.
You must implement strict suicide precautions. The sudden, catastrophic drop in dopamine levels leaves the brain completely devoid of hope. It frequently triggers severe, acute suicidal ideation.
That makes a lot of sense, sadly.
You must ensure the patient's environment is safe and that they are continuously monitored for self-harm.
We use this pattern recognition, the vital signs, the pupils, the behavior shifts, to keep our patients safe. But we also have to talk about the reality of the environment we work in, you know?
Yeah, we do.
We are working long hours in high-stress units, surrounded by these exact same medications.
Healthcare professionals are not immune to substance use disorders. In fact, the intense trauma of the job, combined with direct access to powerful medications, makes nurses uniquely vulnerable.
What does that actually look like on the floor? Like, what are the bedside clues that a colleague might be struggling?
The clues generally fall into two categories: behavioral and clinical. Behaviorally, you might notice a colleague taking frequent, long trips to the bathroom.
Right.
They might consistently arrive late, or you'll notice them isolating themselves from the team. A major red flag is if a nurse consistently volunteers to give pain medications for other nurses' patients.
So they act like they're being helpful team players, but they're actually seeking access to the drugs.
Yes. Clinically, you might see frequent discrepancies in their opioid counts or an unusual amount of medication wastage.
Meaning what exactly?
Like, they might drop half a vial of fentanyl and claim they wasted the rest, when in reality, they diverted it. Another chilling clue is if their patients consistently complain that their pain medications aren't working.
Because the patient never actually got the medication.
Exactly.
I want to put myself in the shoes of a brand new nurse for a second, fresh off orientation. The idea of noticing these signs and reporting a veteran ICU nurse who has been there for 15 years is terrifying.
Oh, absolutely.
It feels like career suicide, or like you're destroying their life and getting them fired.
I hear that completely. It feels like a massive betrayal of a teammate. But we have to reframe this reality. Following your facility protocol to report an impaired colleague, usually to your charge nurse or supervisor, is an ethical and legal obligation, yes. But more importantly, it is an act of deep compassion.
How is getting someone in trouble compassionate?
First, you are protecting innocent patients from severe harm. An impaired nurse cannot safely care for a critical patient.
That's very true.
Second, you are potentially saving your colleague's life. If they are diverting fentanyl or using substances on shift, they are on a fast track to a fatal overdose.
Right.
Furthermore, substance use disorder is a disease, and the great news is that many states have alternative to discipline programs for nurses.
How do those work?
If a nurse is found to be struggling with addiction, the goal of the Board of Nursing isn't always to immediately revoke their license and throw them away.
That's a relief.
Yeah, these programs are designed to help the nurse get into intensive treatment, achieve recovery, and eventually return to clinical practice safely under monitoring.
That completely changes the perspective. You aren't sending them to a firing squad. You are getting them into a lifeboat. You are throwing them a lifeline when they are drowning in a disease.
Speaking up is the most courageous and caring thing you can do for a colleague.
This has been an incredibly practical discussion. Let's summarize the core takeaways so you can walk onto your next shift ready to apply this. Mastering substance abuse at the bedside is all about pattern recognition and understanding the physiological why.
Remember, the golden rule intoxication and withdrawal are almost always opposites.
Always anticipate what the body will do when the drug is suddenly removed. If it's a depressant like alcohol, expect a dangerous hyperactive spike in vitals and prepare for seizure precautions. If it's opioids, expect severe flu-like misery and autonomic arousal. If it's stimulants, prepare for a profound dopamine crash and implement strict suicide precautions. Always prioritize your ABCs: airway, breathing, circulation, and patient safety.
Hopefully, this isn't just a list of symptoms to memorize for an exam anymore. It is a logical, physiological cascade that you can predict and manage.
Which brings us to a highly practical clinical tip for the floor. When you are doing your admission assessment, always ask your patient exactly when they had their last drink or their last dose of a drug.
That is so important.
Don't judge them, don't lecture them, just get the data. Why? Because that timestamp is your bedside timer. It is the exact key to predicting when their withdrawal symptoms will begin to peak, allowing you to get ahead of the crash before it becomes a full-blown crisis.
That is the difference between reactive nursing and proactive nursing.
Before we go, I want to leave you with a final thought to mull over. We've talked extensively about the patient's biology, but what about our own psychology? How does our own subconscious stigma about addiction change the way we assess a patient we label as difficult?
I mean, do you hesitate to push IV pain medications for a patient with a known history of substance use, even when they're sitting there with a visibly broken leg?
Recognizing our own internal biases is the very first step to providing better, more equitable patient care. Think about how your assumptions might be clouding your clinical judgment. Keep that image in your mind, the heart rate spiking, the sweating, the anxiety. Now you know it's not just a mystery. It's a pattern you can recognize and treat.
You've got this.
Remember to check out the new comic book-based video on YouTube. The link is in the description. Like, subscribe, and leave a comment. And be sure to visit supernurse.ai for incredible resources to help you become the super nurse you were born to be. The bedside is waiting. See you next time.